Thank you all for joining us this evening for the COVID-19 Practice Reopening Strategies webinar, better known as Reopening an Independent Medical Practice During COVID. Our speakers today are Erica Adler, attorney, and Kathy Najarian. Before I introduce them, we are going to just go through a few housekeeping. So all of the attendees are currently muted. You will remain that way, but if you do have questions, please type them into the Q&A box found on your screen, and we will address the questions after the presentation. If you have any technical issues or something that you feel would be beneficial for all to see, don't hesitate to type it into the chat box, and we'll do what we can to see if we can help you. Slides and a recording of this presentation will be available on the AOA website. And then a reminder that to obtain your CME credit, you need to take the post-evaluation, which will be available following the webinar. To do that, you'll need to visit the AOA Online Learning platform, the address here on the screen. You will go into the actual course, and within the course, you will see the post-evaluation. Once you take that examination, you will be able to print your own certificate for your own records, and then also let you know that the AOA will be reporting that CME to our CME department. Disclaimer basically saying that this should in no way be construed as legal advice. This is strictly done as an educational benefit for you, just to help you do the right things for your practice, and that the information is current as of the date the lecture was written. So to get started, let me tell you a little bit about our speakers. Ms. Adler concentrates her practice in regulatory and transactional healthcare law. She represents individual providers, physician groups, and other healthcare entities. Ms. Adler has extensive experience in compliance counseling, structuring and implementing complex joint ventures to comply with the state and federal health laws and regulations, including Stark, anti-kickback statute, fee-splitting concerns, the corporate practice of medicine, and other restrictions on healthcare professionals. Ms. Najarian specializes in advising healthcare provider organizations regarding direct-to-employer innovations, value-based contracting, and reimbursement and payer strategies and negotiations. Kathy is a dynamic and results-oriented healthcare executive with a 25-year track record. We're thrilled to have them both here with us today, and I will turn it over to Erica. Erica.
Hi, thanks so much for having me. And Kathy and I are really excited to be talking with everyone today. This is a really important topic, and I don't know how many of you closed your practices during COVID, how many of you have reopened or are just considering reopening. If you're like most of my clients, you might be open but not quite back to business the way you were before. Well, what I want to talk about today is really what happened when COVID started, how were practices impacted, and how can you get back to business in the safest and most effective way. All right, so let's get started. We can go to the first slide. So first of all, just for a little bit of history, I want to kind of talk about what happened when the United States was closed. We know that a pandemic was declared on March 11th. We know that states around the country started to close down, earliest California, Illinois shut down back in March. We know that medical practices were deemed essential services, but they were limited to non-elective procedures in most states. Some of those elective procedures started coming back sooner than others. And now, as of June, all the states are open. Now, that comes with a caveat. Every state on a day-by-day basis is opening and closing, limiting services depending on the capacity they have. So in many states, practices are still continuing to be affected. And unfortunately, we don't have COVID under control yet. So will there be more shutdowns? It's very possible. How will practices weather those shutdowns? Will things be different this time around than last time? I don't know, obviously. All we can really do is prepare your practice to be in the best possible situation to continue to operate as much as it can. If it does shut down, hopefully this will help everybody get back on their feet quickly should it reopen again. All right, let's go to the next slide. Okay, so first of all, I don't want to spend a lot of time on this, but there was some specific reopening guidance that was made available. Everybody saw the White House plan. Every state had their own plan. In Illinois, you can see some links to what those plans look like, but every state, on every state website, there was a plan that gave some guidance on what they recommended practices do. Many state health departments did a pretty good job. They gave some guidance. They told you, what to follow, where to look. The best guidance that really has been out there, despite the criticism that they've undergone, is the CDC. And OSHA as well has done a really good job. Different medical associations have put out guidance specific to the specialty in terms of recommendations that they have to make. So whatever specialty a physician is in, whatever subspecialty, there is guidance available. The common element under all of that is what the CDC and OSHA recommends. OSHA being the most important in some ways, because employers are required to meet OSHA requirements to protect their employees. And of course, employees who feel that OSHA requirements are not being met have created quite a bit of headache for practices as they reopen. And it's something we're going to talk about as we go forward. So again, these are kind of the targets of where you want to look. Let's go to the next page. What I also want to talk about is how were practices really impacted? So did it really make a difference? So we have the country shut down. We had some practices start to reopen slowly around the country. There was lots of guidance thrown out there for practices to take a look at. But really, were practices harmed by this? I'll tell you, we represent thousands of different physicians. Some practices were really busy during COVID. Some shut down completely. Some were moderately affected. They were able to pick up telemedicine. They were able to still schedule appointments. Some only saw emergencies. So I really saw a vast array of how practices were handling the situation and how they were being impacted financially. And Kathy's going to talk a little bit more about the financial piece of it. But some of the data is really significant to look at. MGMA reported that the negative financial impact caused by COVID was reported by 97% of practices. I saw a little bit lower number, but these are the people that were reporting. Practices reported decreases of 55% in revenue, 60% in patient volume, procedures falling by 76%. 81% of administrators reported applying for government assistance. 62% got emergency payments or deposits from CMS. Physicians cut their office staff, and that itself is a completely separate topic that I've spoken with on many occasions about how practices handled their staffing situation. And 15% of practices reported either closing permanently or temporarily. So these are really significant numbers. We can see that definitely COVID affected practices across the country. All right, next slide, please. Okay, so some practices are still reporting that, we're ready to open. And in fact, maybe we've even opened our doors, but patients aren't necessarily coming back. And this is a really interesting situation. Why aren't the patients coming back? Doctors thought they'd be flooded with patients when their doors open, but in fact, that hasn't necessarily turned out to be the case. Some of the reasons that patients appear to be staying away are the following: the demonstrations that they see going on in the streets, maybe a little bit less so now, except maybe downtown Chicago. But certainly around the country, off and on, there's been a lot of demonstrations and violence that have scared people into staying home. Some people have just desired to put off treatments until the pandemic is over. They want to know that they can go out and be safe, and nothing matters more to them than keeping, away from COVID. Some people have lost their jobs. They've lost their health insurance. They can't afford it anymore. This is keeping people from going out and seeking care. A lot of patients appear to be assuming that physicians are too busy due to the pandemic. There's been lots of reports that physicians are in fact not busy, and when they reach out to patients, patients say, oh, I thought you'd be so busy handling the sick patients because of the pandemic that I put off coming in. And this is obviously not true of many practices. And with my clients who have faced this, I've encouraged them to reach out to patients, let them know the availability that they have. That's something for everyone to consider. And finally, the most important, I think, is that people believe that by going to the doctor's office, they're actually going to get sick there. And this is really important and kind of feeds into what we're going to be talking about in detail this evening is, why do you need policies as you're reopening your practice? Part of it is to protect you, and we're going to talk about that. But the other part is so that you are operating your practice in the safest and most efficient way possible, and that you can communicate the steps that you're taking to patients. If patients are afraid to come in, it's going to affect your patients, of course, but it's also going to affect how busy your practice is and how quickly you can get back to normal. All right, next slide. All right, so when you're thinking about reopening, it sounds great. Let's just get back to normal. I want to get busy. I want to see patients. But there are some issues to think about. And this is true not just of physician practices, but all business owners that are out there right now. So one of the things we think about is what happens if a patient comes in and they get sick when they're in our office, and then they sue us for having gotten COVID in our office. And this is a very significant question that I get asked very often by my clients. First of all, if somebody is going to sue you, and this is true not just of COVID, but of anything else, they're going to sue you. And you cannot stop someone or take away their right to sue. One of the things that many practices are doing is saying, well, if they do sue me, is there anything I can do to protect myself? And so one of the things that you'll see now, and by the way, this is not just true of physician practices, but if you have kids signing up for activities, some schools are doing this, anywhere you're going, you're being asked to sign a waiver. And what that waiver is saying is, hey, if you come in and you get sick, I'm not responsible for you getting sick, meaning the practice is not going to be held liable. So one of the things that we are doing as our practices reopen is recommend that they use a waiver. It doesn't mean a patient can't sue you, but it does help to have it in place. That's only one of the things, though, that you can possibly do. We also recommend training for your staff and having thorough policies in place that will reduce the risk to both patients and staff. So a patient is less likely to come in and want to sue you if you have those policies in place. We also recommend that you make sure as you're opening or before you open, if that's the case, that you have appropriate insurance to cover illness for you and your employees, and also insurance to cover bad behavior. And I want to talk about what I mean by that. I didn't want to call it, shooter insurance or anything hostile like that. But in fact, we have a pretty serious problem going on in this country, which is that people who don't agree with the policies about whether you should wear a mask or not wear a mask or whatever protocols might have been in place are often behaving badly. And while sometimes that is just yelling and screaming, it can be throwing things, there have unfortunately been some cases where these individuals have used a weapon, including a gun. And it is being recommended that you review the liability insurance that you have in place for your practice if something terrible like this was to occur, which of course is unlikely, and we would hope that would not happen. But for a thorough review of your liability as you open your practice, this is something to think about. And then finally, the waivers. So what I want to say about waivers is that there's lots of forms available. I do recommend that maybe if you're working with a lawyer, that you have the lawyer review it. There are some things that can be waived and some things that can't. A waiver is a great thing to consider if you're going to use it, but you've got to use it right. Now, what are the kinds of things, though, that patients really are going after practices for? So you open your practice and you get sued by a patient. What kinds of lawsuits are we seeing out there that patients are actually bringing? Because they are bringing them. And patients aren't the only ones. People going to any kind of business are bringing lawsuits. At our firm, we've been tracking COVID litigation around the country, and we're seeing a lot of lawsuits, unfortunately. And the type of claims that are being made are those that are listed here under number 2. Failing to warn the plaintiff about potential exposure to COVID-19, negligence in operating a business leading to the spread of COVID-19, failure to have proper screening protocols, failure to exercise reasonable care related to rendering services during COVID, failure to comply with mandated state and federal restrictions resulting in injury to plaintiff from COVID-19. So you could see how all of these kind of fit together. How do we warn people about potential exposure? We do that by giving them notice and having them sign a waiver. How do we make sure we're not negligent when we operate our business? We make sure we're meeting CDC and recommended guidelines. Do we have proper screening protocols? Are we exercising reasonable care? So you can see how all of the things that I'm talking about here kind of come together in terms of the lawsuits that we're seeing being filed right now. And what we're going to talk about now is how do you effectively put into place protections to make sure that you're not on the other side of any of those lawsuits. And we're going to talk about that. One other thing I want to mention is that there has been an effort around this country in various states to pass legislation that will protect businesses and provide immunity from any kind of COVID lawsuit. In Illinois, there's nothing yet like that, and there's certainly no federal statute like that. However, there are quite a few states that have passed laws like that, and we may see something locally, we may see something in every state. What the states would like is for there to be a federal protection, and we may or may not see that. Obviously, the government's pretty busy with a lot right now, and this isn't one of the topics that is up for debate at this time. So we'll have to keep an eye on that. Next slide, please. All right, so as we talk about the risk to employers in terms of opening your practice, first, we must follow federal and state guidelines. OSHA absolutely requires that you provide a workplace that is free from recognized hazards that are causing or likely to cause death or serious physical harm. You as an employer must review CDC, OSHA, state requirements. The more safeguards you adopt, the better if there's an argument or a lawsuit against you about how you handled things. You should also follow the standard of care set by the local community, your local specialty boards, etc. So a lot of the physicians I work with, I'll talk to them and they'll say, oh, we're doing this and we're doing that, but we don't feel like we need to do this. And I say to them, 90% of the practices in your area that I'm working with, and we represent enough practices for me to be able to make this statement, are doing X, Y, Z. You're doing X. Is that enough? The standard of care in a community is set by what most of the people are doing in your profession. So if every doctor is taking temperature and you're not, every doctor is making people sanitize their hands, every doctor's giving out a questionnaire, every doctor's requiring masks, and you're not, then there is an argument legally that you're doing something that puts you below the standard of care. And I know most physicians are familiar with the standard of care when we talk about professional services, but the notion of standard of care actually goes beyond professional services. And it's just a way of evaluating whether you did what was expected of you in the community when compared to your peers. Finally, I really want to mention workers' compensation liability. So you may or may not have heard this, but there was actually legislation that occurred in Illinois and in many other states related to workers' comp. And what has passed is a presumption. So what happens is that if there's a workers' comp claim against an employer, there is now a presumption that the employee became sick in the workplace. And the employer is the one who must rebut that presumption. So if you have an employee who becomes sick and they file a workers' compensation claim against you, you're going to be in the position of having to prove that they did not get sick or were unlikely to have gotten sick in the workplace. How do we do that? We do that by making sure that the workplace is safe and you've taken every step necessary to protect your employees. And we're going to talk next about how we do that. All right, so hopefully you can see how this is fitting together. We want to protect ourselves from lawsuits. We want to protect our employees. We want to protect ourselves from workers' compensation claims. We want to protect ourselves from any type of argument that we're not meeting whatever the established standard is that has been adopted for our specialty. All right, next slide. So One other thing I wanted to mention about waivers, because I feel like there's some confusion out here. When you're giving a waiver to a patient, I wanted to always kind of make sure that people understand. I've seen doctors send me samples of some of their waivers that they're using. It's really important that a waiver, if you're asking somebody to waive their rights, it should be a standalone document with clear language. It's easy to understand. You don't need to go into details about what steps you take in to protect your practice, okay? You need to make it clear that a waiver is required if a patient wants to come into your practice. Now, I understand that each of you are going to have to evaluate if this works for you. Certainly not everybody's comfortable with a waiver. There's a lot of patients who don't speak English very well or won't have an understanding. They may refuse to sign, and some doctors are simply not comfortable. If you're the type of doctor that is comfortable asking for a waiver to be signed, we want it to be clearly written. We want it to be given before somebody comes in. We want them to understand that it is a requirement for them to obtain services. We do not ever require a waiver where somebody has an emergency. Obviously, minors cannot execute waivers. And most importantly, since we were just talking about employee-employer relationship, you should not be asking your employees to sign a waiver. Employees do not actually have a choice. They have to work. So it is not an independent decision where they can truly waive the risk, okay? You must have a waiver that's signed. You can't just post a copy of it somewhere for people to read. And to make it most enforceable, you really want to have it signed in advance. So the most important thing really to take away from here is that you have to have a process in advance where you're letting patients know what's expected of them. But on the other hand, patients are only one piece of the risk posed to a practice. In fact, employees, in my experience so far with COVID, are posing a much greater risk to practices. Unfortunately, waivers do not work for employees. But we're going to talk about how you can protect yourself against the risks that employees do pose to you. Okay, so let's go to the next slide. One of the most important things that practices can do, taking everything we've talked about so far and putting it into effect, is to have policies. These policies should cover everything about how you're going to address the COVID situation in your practice. Every policy that you write for your practice has to be written for your practice. There are no canned policies. First of all, I don't know if there's any available out there, but even if there were, a policy is not going to be effective if it doesn't match what your practice actually looks like and what you're doing. So you need to take the time to write down what the policies of your practice will be. And you need to continuously update these policies. Okay, the laws are changing, the CDC and OSHA guidance is changing, your policies regarding your employees and how you're handling your patients might be changing. So you need to continuously update it. And most importantly, you need to train, meaning your employees need to be told what's in those policies, they need to practice how to handle what's in those policies, and they need to be continuously trained. All the parts of a policy are important, whether it's cleaning protocols, handling patient protocols, whether it's following up with patients on what your protocols are. Training is the most essential thing. Having a written document that nobody has read or understands is not very helpful, and it won't protect you when the time comes. Again, watch for changes in regulations and guidelines, and of course, contact your insurance carrier. They provide some great guidance on what they want to see in your policies. I know not everybody thinks about calling their carrier, whether it's your malpractice insurance carrier or just your general liability carrier. I've been very pleasantly surprised by some of the guidance that they have put out that's available to you as well. So what we want to do and what we're going to talk about here is how to write the policies and what needs to be in those policies. We know what the risk is. We know that you could be sued by patients. We know you could be sued by employees. We know OSHA can come after you. There's lots of risk in opening up your practice. So what should be in those policies? Let's go to the next slide. What I've outlined here is really just a sample of some of the policies that I've worked with different people on. And some of it may seem obvious, but the thing is that if you get a visit from OSHA, they want to know, what is your policy? And if you start describing it to them, you might leave something out. But if they can see your written manual, they see that everyone has signed off, that they've received the training, that they've reviewed the manual, they can see when it was last updated. This goes a long way to protecting you in that kind of lawsuit. If an employee brings an OSHA claim against you, or a workers' comp claim, remember I mentioned for workers' comp, it's a rebuttable presumption, meaning that employee is going to be presumed to have gotten sick in the workplace unless you can rebut that. How do you rebut that? You show all the steps that you've taken, all the measures that you put in place, and this becomes your rebuttal that they could not possibly have gotten sick here. Look at all the steps we've taken. So here are just some sample policies. First of all, policies on protective measures for staff and patients. This is really just about PPE. You have to do whatever matches your practice type. What type of PPE do they need? Do they need masks that require respiratory training? Do they need shields and goggles? Are you wearing gowns, face shields? Do you need HEPA filtration, UV sanitization? Whatever you're using in your practice, we want to see it outlined. And in fact, if that outline doesn't look very complete, you might come across some things that might be missing from your policy. So we really want this to be a very thorough, robust. How often are things changed? How often are things replaced? How do you sanitize? Some people are sanitizing by putting the mask into a paper bag for 3 days, and then on the 4th day, it can be used again. That's been recommended by some specialty organization, and a lot of people are following that because there's a shortage of masks. But if you don't mention that and everybody's only got one mask and they're wearing the same mask every day, that's not a great policy, and it doesn't really look like you understand that PPE needs to be monitored and needs to be sanitized, etc. So the more detail we have on that, the better. Another policy is how patients should be handled when they arrive at the practice. And I've seen a wide variety of approaches. And in fact, I've gone to the physician, I've taken my children to the physician, and I'm seeing really most places are being pretty good about this. A lot of people are asking you to call or text from the car. They might send somebody out to the car to greet you or out to the lobby to greet you. Usually they're reviewing, the questionnaire with patients, checking patient temperatures, making sure paperwork is signed, including those waivers and any kind of informed consent that might be needed, checking for masks, sanitizing hands. If somebody has to come in with a guardian, then they're having to go through the same process or they're being asked to wait outside. So we're really having a very thorough process. And of course, what I recommend is that actually patients go through this partially before they come in. They should be getting the paperwork and hearing from the practice ahead of time what's going to be expected. They need to come in with a mask. They need to have their paperwork signed, etc. So this policy is really important. I've been to quite a few practices now where there haven't really been any changes. I don't see that the waiting room is any emptier. I see people, just all standing bunched up together at the front desk. This is just not what the protocols are that are recommended out there. I think those practices are not taking every necessary step. But again, there's a wide variety of ways to handle this, and I'm only recommending that you handle it in the most cautious and preventative way that you can to limit your liability. Okay, next slide. So I also include here a couple of sample slides. One of them is alerting management and authorities if there's an infection. So we want to have a process in place where employees are immediately knowing who to call if they're not feeling well at work or when they get home. If you have infections, COVID infections in the practice, who do you call? Depending on your size, you may need to call the Department of Public Health. Depending on where you're based, you may need to inform the hospital that you're at. Whatever the situation is, you need to have that protocol. You need to know who's in charge. You need to know how you're going to handle it. And people often leave this out, and then when they don't know what to do and they're scrambling when somebody becomes ill. How do you handle patients when they are actually in the office? So not just arriving at the office, but actually in the office. A lot of practices are really specific. They have maybe spots on the floor where you can wait. They might have directional arrows where to go. They may only take credit cards, not cash. They may have limited their appointments. Whatever you're doing, we really want to kind of see that spelled out. It goes a long way to show we did everything we could to minimize too much interaction between patients who were in the office at the same time, and things like that. I understand that if you have, patients that are more ill, especially an elderly patient population, some of this is somewhat more difficult and may need to be tailored to your particular practice. These are just guidelines for you to think about as you're developing these protocols. Okay, next slide. How do we handle employees once they're ill? Now, I want to mention that I've had any number of practices who have employees that have actually become COVID positive or shown signs of COVID. So this is actually something that many employers are really struggling. You need to have a very clear protocol in how you're going to handle them. How long do they need to stay home? When can they come back? Well, what about the people who work with them? Typically, you have to let people know without revealing who the person's name is, of course, but in a small practice, that really makes no sense at all. What do you do when you have employees that want to travel out of state to areas that are deemed hotspots? Do they come back to work? Do you make them quarantine, right? What happens if you have people working for you and their children are sick or a family member sick? So you need to have guidelines, but you also need to know what the law requires. And this is really important. You need to know what your policies provide. You need to talk to your lawyer and find out if you're going to be complying with the federal rules that came out that provided for extended family medical leave and paid sick leave, or if you're too small and can opt out of that. So you really need to know what your policies are going to be, and you have to let your employees know what that is. Next is a policy on cleaning and disinfection. And this may seem really obvious, but actually the CDC came out with specific guidelines for OSHA. You are really supposed to be following particular protocols, and you're also supposed to be training your staff on how to handle those cleaning supplies properly. So, not everybody has known how to do it, has been trained how to use particular types of cleaning supplies. They may need that training. There is a risk to them. And also I like to kind of develop a specific schedule. How often are the bathrooms being cleaned after every patient uses them? Who's responsible for that? How often are treatment rooms being cleaned? When do you need a deep clean? If you have COVID patients coming into your practice, how are the policies different? Do you have a specific room for them? Do they only come in at specific days and times? Do you have specific people only? What do those people wear when they're doing cleaning? So really some of the things to think about so that if somebody does become ill in your practice, you can say, these are the policies we follow. We really don't believe that they became ill here. We could not have done more. So that's kind of the argument that we want to make by developing these policies. Okay, next slide. And I'm not going to spend too much time on all of these, but you see this policy on physical office changes and structures. A lot of people put up plexiglass. They took chairs out of their operating rooms, separate entrances for symptomatic patients, eliminating things from the waiting room so people aren't touching them, limited use of break rooms. Break rooms are a real problem for many physician practices because you do such a good job during the day. Everybody's wearing their mask, everybody's behind plexiglass, sitting at their desk. But when people go eat lunch, they're all there, they take their mask off and they're all together. That's the number one place that most of my practices have had their employees spread COVID. So just be aware. What we've done in many practices, come up with a lunch schedule. So everybody gets X amount of time. They have their set time. They go in then, clean up after themselves. It can be, a pain for sure, but these type of precautions kind of help. And of course, what happens if your staff gets sick, it totally affects how the practice can operate as well as your productivity. Changes in employer policies and training. This is important. It should be obvious. Any of the things we're talking about that are different than they used to be before, you need to train your staff. You need to train and retrain. I have found that some practices did some very early training on cleaning and PPE, etc. A month later, people were doing it all wrong. It requires constant training and retraining, and just making sure that people understand. Usually we like to designate particular people in a practice, depending on your size, to be responsible for certain types of training, and repeating it fairly often can be helpful as well. All right, next slide. Treating patients who are COVID positive, how do we handle them? It may seem obvious, but some of the staff working for you, the receptionists or MAs, they just aren't necessarily understanding how, viruses get transmitted and the steps they should be taking. We also want to have policies on how we're going to handle patients differently. If we find out somebody has an appointment, we like to recommend you call up ahead of time. Hey, have you had a fever? Are you having any symptoms? And to have a policy so we can communicate to those patients, okay, we're going to come in, but this is only, Amy's going to handle you, and you're not going to talk to anybody else. You're going to go to a specific room. Or if we're not handling COVID patients, saying you need to call us back and reschedule in 10 days. So you need to know what your policies are. You have to train your staff, I guess, on that as well. Policy on adjustment to patient services and interaction. Really, we're just talking about having a clear outline of what types of patients you're going to see, what types you're not going to see, changes in office hours and services, when telemedicine might be available. We're talking about signage that outlines your practice policy. And really, why aren't doctors sharing this information? Put it on the website, send out email blasts, send out messages. I've been bombarded by some of my physicians with this information. Others don't even have that technology. It's pretty quick and easy to get. And I think most patients are pretty connected these days. And, they can always refer back to the website and the email if they know it exists. Again, these policies are not just for you, and they're not just for your employees. If you can convert the things we're talking about to a policy that you can share with patients about the safeguards that you're taking to protect them. Patients want to feel safe. They want to know when they will come in that you are the safest shop in town. You're taking every possible precaution. And they like to see outlined exactly what those precautions are. Okay, my final slide before we switch to Kathy, if you want to go to the next slide, is really new. And I wrote new there. I added this slide because I really feel like these things are things that I wasn't thinking about when I first started talking with practices about their policies, but I think these are really important issues that have become the ones I hear about most often. So first of all, safety. And I kind of mentioned this a little bit earlier about patients coming into the practice and being angry about having to wear a mask, and some of them becoming violent or threatening staff. Nobody wants that. And I don't know that we could ever completely eliminate it, but there are some steps that are recommended to prevent this. First of all, have those clear policies. Patients shouldn't show up and find out what your policies are. Obviously, that sets off people when it happens. Actually, people who know about it and show up and find out that those policies are true are set off. But we can only do our very best. Have clear policies. Let your patients know what to expect when they come. They will be wearing masks. They will have their hands cleaned. They will have their temperatures taken. Put this on your website. Send out emails and notices. They cannot say they did not know. If they don't like it, they should not come in. And you can let patients know that. If they prefer a practice where those safeguards are not taken, then you're not the practice for them. A designated person should be assigned to handle non-compliant patients. The average front desk person may not be the one who feels they have the authority or is comfortable in that position. A lot of times my practices will have the senior physician or the practice manager, whoever has the personality and authority to be able to handle that, be the one who is called immediately. The practice also should have a protocol to be calling the building security or 911. And, I posted something similar. I wrote an article about this recently, and I got some emails from people saying they absolutely disagree with this piece of advice. Well, you can take this advice or not take this advice, but when somebody comes into your practice and they have a weapon, you need to know. You can't freeze. You have to be prepared to protect yourself and your practice. And it's unfortunate, but I feel being prepared is better. I'm not talking about unnecessarily calling security or 911, but having people trained to know what to do. Use a firm approach. A lot of times if a patient starts making a fuss, somebody will say, oh, okay, we'll make an exception for you. You need to be firm and you need to stick with it. Everybody in the practice needs to believe that these are your policies and there are no exceptions. Okay? And by the way, let me point out that there are no legal exemptions under ADA, HIPAA, or any other law. Anybody presenting a card or something like that, it is fake. There's no government organization on the freedom to breathe or anything like that. I don't know if any of you have seen that out there, but that is just false and made up. Are there medical conditions where people can't wear masks? Well, you're doctors, I'll leave that to you. But one of the things that you can talk about with patients when they're making their appointments is there any reason they feel that they cannot wear a mask? And the doctor can then work with the patient to address those concerns and find a safe way for that patient to obtain services, or if you don't feel it's a valid medical issue, then they can seek services elsewhere. So finally, on this point here, just want to remind you that having a firm approach will protect everybody and give the message that this is what's expected when you come to the practice. There are some physicians out there who do not share the view that masks are necessary or that these safeguards are necessary, but I'm not looking at this from a political or a public opinion. I don't care what anybody's personal philosophy is. My perspective here is protecting the practice from a legal claim, like by a patient or by an employee, whether it's workers' comp or a lawsuit. So these are the steps to protect your practice from those perspectives. And whether or not you believe these steps really are going to prevent COVID or not is very different than, wanting to do whatever you have to protect your business. And finally, what about those non-compliant employees? They're posting on Facebook, they're out on the weekends, they're at concerts. They're the ones that are getting sick, and it makes other people in the practice uncomfortable. This is the number one issue that I get calls about. What do we do about employees? We know that they're following the guidelines in the office, but they've already had symptoms of it once. They came back. We see they're still posting and going out. This is a conversation really that you should have possibly with your lawyer if you work with one, but you should be familiar with your contracts. You should know what rights you have to terminate your employees if necessary. Most employees are at will, meaning they don't have a contract. You do not need a reason to terminate somebody under those circumstances. You just have to follow your own policy. So somebody you believe is posing a risk to your patients, to your business, to your other employees, you could just say, I'm sorry, we don't need you here anymore. Do not give a reason. And of course, we don't discriminate. We treat everybody the same. And of course, that is really important. If people are being bad, you can't just choose the ones that you like and not the others. So I think that's it really. And of course, if anybody has any questions, I'll be able to answer those at the end, and I'll turn it over to Kathy now.
Great. Thank you, Eric. I appreciate it. We're going to transition now from helping you get your practice back up and running and what Erica provided from a legal compliance regulatory standpoint to really more the financial area. My background has entirely been supporting hospitals and physicians in their interactions with payers, both governmental and commercial payers, and in a managed care contracting role. So I have worked with the Blue Crosses, the Uniteds, the Aetnas for my whole career. And what I'm going to talk about is really how you can partner with the payers to help with financial recovery. This first slide is really tied to a blog I wrote way back when COVID started, kind of late March, early April, where already I was concerned about the financial situation this was going to cause for our physicians and hospitals. The minute they said elective procedures needed to be canceled, ambulatory visits, we know that is the profitable revenue that is coming into all of your practices and the profitable population, your employer-based population. So really this 5 steps was created to really start getting our providers ahead of the curve, even before shelter in place ended, start thinking about how you reopen your practice. And we're now obviously in the middle of these steps, but the first thing was you need to really understand what is the financial situation created by the COVID situation, canceling procedures, that type of thing. And so having a modeling, forecasting, it doesn't have to be sophisticated depending on the size and complexity of your organization, but you really need to be continually monitoring your monthly finances. We know that a lot of organizations have come back up. A lot of them have come back up to 50%, 70%, 80% of what they were pre-COVID. I'm not aware of too many organizations that have come 100% back to both the volumes and visits and revenue for, the time frame we're now in the pandemic. But that is a lot of the stuff that Erica talked about really was enacting your reopen strategy and how are you going to manage your non-COVID patients at the same time that you're also caring for COVID patients. And what I'm going to really focus on today is really 3 and 4, which is developing a plan to recapture your lost revenue and exploring partnership opportunities with insurance companies, employers, that type of thing. And then kind of ending with some of the good that has come out of this. Everybody now has coined it the new normal, and there are some good things in healthcare that have come out of this new normal. Obviously, telehealth is an amazing new opportunity that I'll touch on just a little bit. Next slide. So this financial stability matrix is really just a visual to show the crisis caused by COVID-19. Anything in red is really bad from a financial standpoint for our four stakeholders, which are, of course, all of you, the providers. Then we have your patients, which are also covered through employers. We have the government, and we have insurance commercial payers. And you'll see a lot of red there, especially for us providers, of everything, all of our costs that went up, all of our elective surgeries, visits that went down, our profitable payer mix, our favorable service line mix. All of this stuff went in the wrong direction. The main thing to note on this slide is the insurance companies have some really important greens on their lower quadrant. They're still getting the premiums. They're getting paid, just like you see a lot of advertisements about auto insurance companies, are giving back premiums and credits because people aren't driving. Well, the insurance companies are still getting all those premiums for healthcare services that patients aren't having. So they have a lot of surplus going on right now, where at the same time they had a significant decrease in all of us filing claims. So as some article had out there, which is so true, the only ones immune to the pandemic are insurance companies. And that is really a true statement. Next slide. So as far as trying to understand what your levers are from a financial standpoint as you reopen your practices, you've got kind of two sides of this model. One is really, what do you need to have for the continued surge? We know that things got calm, we reopened shelter in place, and then a lot of your states, especially down south, out west, had a second peak, additional surplus. The Midwest now is going through that. I think the last week or so, things have stayed pretty stable, which I'm glad to see. But this is going to keep happening until we have a vaccine. So you've got to kind of manage both sides of the house. You got to manage your surge COVID situation if you are a practice that is going to be at all involved in seeing these patients. And you got to look at your staffing, your supplies, your capacity. At the same time, you got to look at the financial model and see what is being affected by your cash flow, your revenue expenses. At the end of the day, it's all about your margin, that you need to have more money coming in than it's costing you to manage your practice. And the big thing here that worries me about the margin situation isn't just the loss of volume, and that's starting to pick up, but it's really the payer mix. The amount of people that are now unemployed is staggering. There are a period of time where they're going to have COBRA and access to insurance, but then these people are going to roll off and either have to go to the marketplace, get on Medicaid, or they may be uninsured. So I am very concerned about what this is going to do to payer mixes, where a lot of physician offices are already very heavy Medicare population, Medicaid. The commercial is really where the profitable revenue comes. That's what's going to be shrinking in this situation. So that's where I'm trying to help provide some tips and resources to help manage these challenges. Next slide. And this slide is really designed to offer up what are some of the opportunities to recapture lost revenue. Some of these have already been in place since March and April. Obviously, the government had all types of subsidies that they were offering out there. Some of them were more accelerated payments, which were loans that have to be paid back. Other ones were direct dollars that they were giving to providers based on your previous Medicare claims filings, and those don't have to be paid back. So I will say I've worked with hospitals, doctors of all sizes over the last several months, and that is what has really saved most organizations, was CMS coming out front and giving accelerated payments, and the federal government giving this, non-repayable loans and dollars out to providers. That has kept people afloat till they could reopen and get their volumes up. The concern now is, though, of course, the CMS accelerated payments are coming due. Physician practices were sooner than hospitals, so you're really in that phase now where you have to start looking at paying those dollars back, or they'll start recouping them in future Medicare filings. So I think we're going to see this lead to new financial crisis, especially I think for independent physician offices. So what I'm suggesting is the place to look now is you've gotten what you're going to get at this point from the government. A lot of the bills for additional relief money have stalled in the House and Senate. So I don't know that there'll be more dollars coming out. But the key message is the commercial payers are the ones that hold a lot of dollars, and they're in the best position to help our physician practices. And I do believe they want to keep, especially independent physician practices that are not employed by large health systems. It's very beneficial for insurance to have those independent practices and to keep you viable in business. So some of the strategies I'm going to talk about are about renegotiating your contracts, looking for relief from the payers. That could be as simple as get the payers to accelerate payments, get them to shut off some of their cumbersome requirements that cost you a lot of time and money and denials. The other area is looking for new business opportunities. I know a lot of people see this now as opportunities to partner with other physician groups, to partner with other types of health systems entities, not necessarily becoming employed, but just leverage different types of joint ventures where both organizations can benefit. Next slide. So this is a very complex roadmap. I'm not going to go through this. This visual is really more to show all the touch points in the revenue cycle that all of us are dealing with, no matter if we're a huge, large health system or a solo practitioner physician practice. These are all the cumbersome things that we have to deal with now in the insurance market in the United States. So one thing that I will say is quick and easy for practices to start doing is really look at the revenue cycle efficiencies, and that is the quickest bang for your buck. That doesn't involve renegotiating payer contracts, getting loans from the government. Look at your dollars and see what's going on. Really tackle that upfront process to make sure you're now verifying patients' new insurance, make sure they still have insurance, that you're filing it to the right place, see what's going on with your prior auths and anything you need at the pre-certification level. And then really looking now at the back end, we're all billing new services related to COVID-19 testing, treatment, all the wonderful telehealth services that we've been able to put in place. The billing of those varies by governmental, commercial payers, the modifiers, the codes. These are all new things that nobody's done before. Even now here in Chicago, I'm working with a very large academic health system who has armies of people in their revenue cycle. They're having all kinds of issues with denials and claims not paying right around COVID and telehealth. So it's at every level of every organization. This is new territory. So you really need your back end billers, collection people to be seeing what's going on, because it's great that you've now been able to bill all this service related to telehealth, seeing your patients outside the office. But if you don't get paid for it, there's not going to be any value there. So that is really my focus here, is to say, look at what's going on and seek help. All the payers have pretty robust policies on their website around telehealth, what modifiers to use, how you should be billing it. Check your claims if you're billing anything related to COVID. Unfortunately, I'm seeing payers put some of the dollars under patient portion, and that frankly is illegal under all the government regulations. They made the national insurance companies waive patient portion. So just be aware of that, because we obviously have a lot of patients that are strapped for cash, and you don't want to be incorrectly billing them for COVID-related services when it was really, the insurance company that did not adjudicate the claims correctly. Next slide. Another area to look at is really partnership opportunities. You see a lot of movement going on now where organizations to survive are having to really choose some new partners to work with. And obviously there's different partnerships we're going to look at with the payers, so you can work with them, see if they can assist you with accelerated payments, creative new payment options. Employers is a really good thing. A lot of my background is direct to employer, where I help provider organizations do contracts directly with employer groups, cut the insurance company out of the middle, and really add value there, helping these employers who are also cash strapped now. They really need to help manage their healthcare costs. They will be looking for innovative ways to partner with provider groups. And then partnering opportunities with other provider-based organizations in the market. There's all kinds of clinically integrated networks, accountable care organizations, your older school IPA type arrangements, where they are looking to partner with other providers, both primary care and specialty care. And then again, certainly there's opportunities with your local providers, health systems, ambulatory centers, to look at some JV opportunities where you could share in the growth of new businesses. Next slide. As far as specifically working with your payers, and I'd say this is geared towards your commercial payers, I kind of outline 5 strategies that I think are more immediate opportunities to renegotiate those contracts and invest some new dollars coming back into your organization. The first one is really a site of service revenue conversion. And a lot of this can be, a good example is the telehealth, where the government and then the commercial payers followed suit and said, we will pay you the same as an in-office visit for a telehealth visit. That is just for now. All of that has been temporary. The RVUs are actually significantly lower for telehealth. So if you don't now proactively start negotiating with your commercial insurance payers for appropriate reimbursement for telehealth, they may keep some of this permanent, but they could pay it a third of the price of an office visit E&M code. So I'm encouraging everybody to find out what the payers are doing with their final permanent policies and how you can be proactive and say, I want to get these codes added to my fee schedule and I need these to be added at the same rates as in person. CMS, the government has said they are going to make a lot of their telehealth waivers permanent as well. They're still wrangling with, are they going to pay it the same as an in-office visit or not? Obviously, we can't negotiate with Medicare, but we will, watch that closely and hope that they agree to price the telehealth at appropriate levels. Other opportunities, as most contracts nowadays at every level have different types of quality pay for performance dollars that you can earn money based on hitting quality measures, cost efficiency measures. Those dollars are ones that you can access potentially ahead of time. The payers have had to already set aside these dollars for future payments. So if you're on a calendar year and you're not going to see these dollars till next year, the payers have been very receptive about advancing a prorated amount of what they think you're going to earn under your quality program. They don't lose anything. You get the money ahead of time. And then obviously there could be a true up down the road if they didn't pay you enough or if they overpaid you against final performance. Some payers are putting in place brand new quality programs deliberately just to have ways for doctors and hospitals to earn new dollars outside of the fee-for-service revenue. And then they're expanding that really more on the value-based care side to really offer up now, instead of fee-for-service, more PMPM, capitated payment amounts, so that provider organizations, especially primary care, have a regular, steady monthly income for their patient population. If this keeps happening, or if it happens again, instead of all your revenue plummeting because you're not getting paid for each fee-for-service visit, you have a monthly stipend that's coming into the organization. And I've definitely been reading a lot of articles where both the providers and the payers are embracing these kind of approaches. And then a big one is getting held harmless on any downside risk. CMS, under the MSSP program, a lot of the other programs, has already said they are not going to hold any provider organizations accountable financially if they're under downside risk and due to COVID, they do not hit the cost targets under the contracts. They're waiving that. The commercial payers are not proactively doing that. So I think the biggest message I have is the payers are not going to come to you proactively and say, hey, we want to help you. We want to give you money. They can't help everybody. So you've got to be proactive. You've got to leverage your relationships with the provider reps, the people you know at the payers, and you've got to go to them and say, hey, I need some help, or I may not be able to keep my practice, to stay in business. I may have to sell out to a health system, and you're going to pay more if I become employed because they're going to move me under their, higher fee schedules that they're able to negotiate because they leveraged 2,000 doctors instead of 2 doctors. So there's a lot of avenues with the payers. The big thing is you're not going to get anything if you don't ask. And again, they're not going to come to you and just, hand you free money. So those are some key things to start thinking about. Next slide. And then talking about the new normal, these are some of the influencers that will continue to arise into the fall, into the winter. And you've got to just keep following and understanding your patient volumes and trends. What's your cash flow look like? Obviously, everybody has staff and people that they've got to flex and decide if we're not able to see a full patient load. Do we have some people on furlough? Are we able to bring people back? You've got to manage all that, and you've got to continue to have your policies around managing your COVID patients and really the concerns for your non-COVID patients. I think, volumes have not totally rebounded because patients are afraid to go to the doctor's office, afraid to go to the hospitals because they are concerned that they are going to contract the COVID from being in these environments. So no matter the size of your organization, you definitely have to have protocols and measures in place so patients that are COVID-free can feel comfortable coming into your practice and be segregated from any potential patients that are actually coming in because they do have symptoms of COVID or are being managed actively for COVID. And then you've got to really think about what does your strategy want to be long-term to expand telehealth and other types of digital technologies. Next slide. So I think the three areas where the new normal is a positive in healthcare is really technology, growth, and cost efficiencies. The technology, besides telehealth, you have so many opportunities now to do remote monitoring, all these things that can be done with your patients without physically bringing them into the walls of a practice or a hospital. And, you know, as I mentioned earlier, the key here is being proactive. And as you start advancing these technologies, is ensuring that you negotiate reimbursement with the payers. Because a lot of this stuff is not stuff traditionally that the insurance companies would pay for. So before you put a whole business plan together or invest in technology, make sure you're going to have the reimbursement and it's going to be paid. On the growth side, I think what we all found in COVID was that providers were able to pivot and quickly bring up entire new ICU units, entirely new hospitals, move quicker than ever, where usually it takes our provider organizations weeks, months, years when they want to develop a new service line. So I'm encouraging provider entities to stay in that acceleration that they were able to do during the beginning of COVID and really help bring new services, new programs to market in a much more accelerated time frame. And then cost efficiencies. I think, again, flexing your staff, maybe having some of your non-clinical staff work now entirely remotely, your billers, your collectors, other people on the revenue cycle, the pre-cert, you can get a lot of efficiencies if you don't have to maintain a large office suite of employees. And I will tell you, even the big, large health systems are really talking about having the majority of their financial, non-clinical people start working from home, and then maybe having some hoteling space on the campus, but really allowing organizations to cut back on their property, plant, and equipment for, you know, paying for all this office space. Next slide. And then kind of my last slide is just a reminder on the telehealth piece. CMS initiated several waivers around telehealth. And besides, you know, just the typical one you see on this picture where you're doing an online virtual visit with a healthcare provider, there's so many opportunities. You have the virtual check-in, which is a very quick, succinct check-in with your patients. They're allowing right now telephone, audio only services. So I think, again, we don't know which of these are going to stay in place, but it's definitely assured right now that this is here to stay in some format. So I think you need to stay very closely following what the government, CMS, is doing. And then I believe the national commercial payers will soon be coming out with their policies. At this point, none of them have come out with any permanent policies regarding telehealth, but I would expect over the next few months we will start seeing that. And again, they're going to dictate if you don't come to them. They're going to say, well, this is our policy and this is our standard fee schedule. So again, start thinking about what you need financially to sustain these services and be prepared and ready to negotiate with the payers. And with that, I think we'll be turning it over to questions.
Okay, thank you, ladies. And attendees, please type in your questions to the Q&A box. And I'm just going to give you a few information about some resources, and then we'll go to the questions. So, first thing we have is the physician support line. This actually was developed by a DO, and as this COVID pandemic is affecting all of us, we want to make sure that our physicians, should you have any feelings that you need to discuss with someone or support, please reach out to them. Also wanted to tell you about the osteopathic.org COVID-19 page. This is a page that is on the AOA's website that is updated regularly, pretty much on a daily basis with CMS stuff as it comes out. So please make sure that you check back often to that. And then this is just a sampling of the 14 to 16, I think there were 16 COVID-19 webinars that we've presented since this has started. And this is just a sampling of them. They are available on the AOA Online Learning platform, the address on the slide. And then upcoming, we have a cybercrime and HIPAA Prepare Your Practice coming for September 10th. And then we have reopening your medical practice with the concentration on OMT. So this is going to touch more on the clinical side and the cleanliness type thing and protection that way. And the physician speaker for that is going to be Dr. Brian Lovelace. We have not set a date yet, but it is coming up most likely end of September. Again, that'll all be available on the AOA Online Learning and of course through our normal avenues that we advertise our webinars. And then again, a reminder to go back to the AOA Online Learning platform, go into this specific course, take the post evaluation so that you can get your CME. When you go to the AOA Online Learning, if you have not already developed I'm sorry, my mind just went. You don't already have your password and such, you can create one here that'll get you into the class. And then also some telehealth and COVID-19 resources. These are available to you as well. And Physician Services Department, this is our direct line in, as well as the email. So if there's any questions or anything that you have concerns about or need help with, please reach out to us. And then this is Erica's and Kathy's contact information. So feel free to reach out to them. And we'll go to our questions now. Okay, my practice manager states she cannot negotiate with insurance since we are just 2 gynae docs. Do you feel it is possible to negotiate with the insurance to change fees?
Yes, I certainly do. I think any physician practice, solo practitioner, 2 doctors, I think you're in a good position. Insurance companies, again, really want to keep alive the independent physician practice. And we know over the last 10, 15 years, so many physician practices have sold out and become employed by hospitals or health systems. So the insurance companies are doing a lot of creative things to help keep independent practices afloat. So again, if you don't ask, you won't know. A lot of the Blues plans around the country, Iowa, North Carolina, California, they are literally offering up just to independent physicians additional reimbursement streams to help keep their practices viable. So yes, I absolutely think there are opportunities for any size physician practice to be in a position to get additional relief from payers. It costs them a lot less to help a 2-man group than a 2,000 group or a 700-bed hospital. So it doesn't cost an insurance company very much to give you a additional 10% bump on your fee schedule or have a PMPM management fee monthly for you caring for your chronic condition patients or primary care patients. So yes, definitely make the attempts. The biggest thing is having contacts. A lot of small practices don't really know anybody at the insurance companies. So that's the key thing, is talking to your other colleagues, maybe even people that you work with at your local hospital, and say, hey, who's my best contact at Blue Cross, at United, that type of thing.
Okay, thank you. Well, it does not look like there are any more questions that have come into the mailbox. So attendees, should you think of a question after the fact, don't hesitate to reach out to either of our lovely speakers or to the Physician Services mailbox. I thank you all for joining us, and I thank you, Erica and Kathy, for a terrific presentation. And we thank everybody. Take care, everybody be safe. This concludes our webinar for this evening.